Next speaker is Dr. GAURAV LUTHRA. He's the owner of Drishti Eye Institute in Dehradun, and he has more than 100 international papers, more than 200 domestic papers, and he's very well known for one of his famous instruction courses, Lord of the Rings, which is like in the top 10.
Also IRS. He'll be talking topic.
Can we take some questions till then?
Dr. Gaurav, are you
Thanks,
ready?
Abhijit. Yeah, I'm set up. Yeah. Thanks, Parul, for inviting me, and it's been an amazing course so far. I'll just try to kind of add my 2 cents to this. Okay. So, what if you have a refractive surprise after a perfect cataract surgery and you worked hard for emetropia and giving the patient a great outcome? First of all, I think I would like to clarify here that the definition of a refractive surprise has changed so much over the years that I've been practicing. In the past we would think that a refractive surprise was, a 1 diopter of a surprise would be probably considered 10 years back. Today, even a 0.25 sets you thinking that where are we going wrong? This is the era of optical biometry and so many other things that are available to us. And even a 0.5 cylinder or more qualifies for a refractive surprise today. So one has to be very careful in what one labels as a refractive surprise. So, and the threshold is even lower for multifocal and presbyopia correcting lenses because the image quality can deteriorate drastically when the refractive error is more than even 0.25 or 0.5. So, I sometimes see patients who have received a multifocal implant and astigmatism has not been addressed, and a patient with 0.75 cylinders is coming with a huge amount of dissatisfaction and requires intervention, and that sets me thinking that multifocal IOLs, one has to correct astigmatism even if you're using a 0.25 or a 0.5 cylinder. It needs to be addressed with whichever way you find you're comfortable with. So predisposing factors for refractive surprises are basically extremes of refractive errors, high hyperopia, large myopia, eyes with very steep or flat corneas which may be outliers for biometry, a very shallow anterior chamber depth which will change your ELP, prior history of refractive surgery, and frankly we should all watch out. There are so many post-refractive surgery patients moving around who will not give you a history of refractive surgery, and you may end up with a refractive surprise, and these are the patients who are actually looking for excellent results following cataract surgery. And VR surgery of course adds up to situations where you may get a refractive surprise, and then an irregular cornea and contact lens use, which again, if we are not doing topography for our patients who are undergoing biometry, we may miss patients with contact lens warpage, we may miss patients with inferior steepening, and we may end up with poor results. So whenever using a presbyopia correcting IOL, it's a great idea to look at the a topography as well, and poor ocular surface, as was addressed by Dr. Chitra. So all these, so many reasons for you to end up in a refractive surprise if you're not careful. And then the second thing is setting the right expectations. So when counseling patients for premium IOLs, I think it's very important to let them know that you will not be able to achieve, you will aim to achieve perfection, but you almost never do. And I always tell patients that even with the most expensive lens and the most expensive technology and surgery, we will try to achieve you and bring you to perfection, but we almost never are 100% accurate, and 90% activities may be possible without glasses, but for few things like seeing the very fine print and seeing very fine things in the distance, you will still need glasses. So that kind of lets them know that there may be need for glasses for certain things, and that sets the ball in the right motion. So special at-risk eyes need special counseling. So high-risk patients, post-refractive surgery, other eyes where you are not sure about the biometry, poor ocular media where you may not have a perfect axial length measurement, you have to warn them that there may be possibility of surprises which can be addressed. So, and also of course letting patients know that just in case we have a surprise, we might have to do a second procedure. Now these things have to be subtle, in a subtle way discussed. You don't have to scare patients, otherwise they'll probably not opt for surgery with you. But if you just casually mention it to the patient and the attendant as well, it really helps later on if you've ended up in a refractive surprise. So now once you have a surprise, you have to then make sure that you have all your instrument armamentarium ready. But frankly, today refractive surprises have become less common, even though the bar has been set much higher. Advances in optical biometry and newer formulas have ensured that we get great outcomes. And we have better understanding with artificial intelligence of at-risk eyes. You can be told that this is going to be an outlier, and there's better ways to deal with them as well. So when you do get a refractive surprise, it's best to start tracking your footsteps. Where did you go wrong? Because unless you identify where you went wrong, you will not be able to deal with it correctly. So the issues could be with the errors in planning, or the errors in measurement, or it could be with the errors in execution. So you have to identify where things went wrong, and that's the best way to start looking at how you're going to address it. So error in planning could be so many places. You didn't choose the right lens for the patient based on what his requirements were. You didn't use the right formula. You could have special eyes. You could have errors in data insertion, which often happens, but has been minimized with one and all devices like the optical biometers. And then, of course, you may have missed a previous refractive surgery. For a small correction, you may not be aware that patient actually underwent a surgery. So errors in measurement, of course, unless you're, your staff is really good at doing these measurements, even with an optical biometer, sometimes if you're not looking at the raw data, you may miss patients where there may be errors in topography, in the keratometries, or even with excellent measurements where these machines actually tend to normalize the data, and they use, these newer machines can actually use the data in such a way that they're trying to guess it right. So you have to be careful, and I always look back whenever I'm noticing any discrepancies in the two eyes, for example. I will immediately look at the raw data for these patients, and I often find that you can actually look at find the cause there. So just like this, you could have so much difference in the astigmatism in these three gazes, from 0.9 to 1.4 to 1.9 for the same patient, 3 different cylinder measurements based on how the patient is looking. So this becomes very important, and frankly, none of us is sitting in the room where the optical biometry is happening. Of course, the surgery has to be perfect, as must have been explained by Abhijit in his talk, how, when you're dealing with presbyopia correcting lenses, you want absolutely a perfect surgery. Otherwise, you should be mentally prepared for situations which demand, correction. So if you have a refractive surprise, most important thing is to pick it up early. So all patients on day one should be checked for if they're possibly having a refractive surprise and marked out, and they should be called back early for a follow-up, so that in case you have to deal with it quickly, you can. And by the 2 weeks visit, which is for us the usual second visit for the patient, you are usually quite sure that if there is a refractive surprise. So don't push it under the carpet. Make sure that you're kind of documenting it and discussing with the patient and seeing how much he's impacted by it, and then getting ready to act on it. And then, of course, you have to try and fix it if the patient is not good. So in presbyopia correcting lenses, there could be surprises for both near and distance, which means you got a refractive surprise for the whole surgery, or you may just have a patient who's not happy with his near vision and happy with the distance vision. So if it's just the near ability where the patient is not happy, then it's not a refractive surprise really, but depends on how you build the expectations and the IOL design which was used. So you can tell the patients to use better illumination, the correct reading distance, you can train them. And you can also look at the fellow eye status, try to give glasses appropriately. Nowadays we try to operate both eyes within a week or two of the 2 surgeries, so that patients are much happier, and they tend to kind of do much better especially when you're using a presbyopia correcting lens. So the fellow eye status becomes very important, and you can bring hope to the patient that once you do the second eye, they will usually settle down. If you allow this to go on for 6 months, they will usually not come back to you for the second eye surgery and find somebody else. And then, of course, they'll still remain dissatisfied. And binocular vision really helps with these lenses. And of course, when it comes, so it's a huge topic, so I'm running through it, but there is always going to be a debate between how you're going to correct a myopic surprise versus a hyperopic surprise. So there comes the time for decision making. If there is very often in the early days, you may have, you should, if you have a refractive surprise, you should be looking whether the fellow eye is a myopic or a hyperopic eye, and whether it's a small or a significant surprise. Whether it's a spherical surprise or a toric surprise, of course, monofocal or a multifocal lens, and how symptomatic is the patient, and then, of course, reassurance that things can be dealt with. Very often, it's a capsular block syndrome which is causing this. Even in the early days, you can see this on the OCT very nicely. And if it is that, it can be dealt with in a different way, and this will obviously be very easy to deal with. And then, of course, if we have a refractive surprise, these are all the options which you can do. You can start with giving a small correction. Some patients are actually happy with just a small correction. They don't want a second intervention. Other patients may be dealt with contact lenses, which is rare. But then other things can be dealt with. For example, if it's a toric surprise, you could just do an IOL repositioning within the first 15 days. It usually works really well, but then you have to identify it. We do measurements for all our toric patients on day 1 and day 15 when they turn up for alignment, and then we deal with it if we have to. And then, of course, the other options which are more interventional. So going on, I think I'm going to run out of time, so I'm just trying to see that we can finish this. So I think if you have a wrong IOL, you can do an early IOL exchange or a repositioning if it's a toric IOL. And for this reason, the IOL exchanges have become much more advanced now. We have many techniques for doing IOL exchanges, and if you're using a hydrophobic lens, it's best to do it in time. And rotation can be done very easily. I'll just finish in 10 seconds, Parul, yeah? And rotations can be done very easily for toric IOLs if they are needed. The eye trace is a great device to identify how much rotation is required. And the calculators which are now available online. Another option is to do femto-assisted or manual astigmatic keratotomy. This works really well in multifocal IOLs where there's a small astigmatism, say about 0.75 or something. You can actually correct it without doing much with just astigmatic keratotomy if you know how to do it right. And there are formulas, the Barrett's RX formula, which can be used. So I think the message is clear. The piggyback IOLs, which I prefer to use when there's a patient who's been operated elsewhere and I don't know about the exact surgery which has been done, or in RK operated eyes where you may have a refractive surprise. So the piggyback IOLs have become really good, the ones from Rayner and then now from the CARE group, which have worked extremely well in my hands. So I think I won't show you the surgery, but the last bet is the laser vision correction, which can be done on the surface or with a flap. Both things work really well. Of course, if you want to make a flap, you would have to wait at least 3 months. So I think that covers almost all the situations that can be covered with this in such a short time. And I would like to thank you for that.
Thank you, Dr. Gaurav. That's a very good use of the time that you made. And the main thing which you pointed out is to tell patients, preset it, because we are not saying the presbyopic IOL is to get rid of the glasses. We are saying at the outset that it's to decrease the dependence on glasses, so then any other surprise or, corrective measures can be taken up with in a good way.